Hello and welcome to today's webinar, Setting Standards for Advanced Primary Care Through Medicaid Managed Care, Considerations for Promoting Equitable Pediatric Care, made possible by the Commonwealth Fund. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, audio lines are muted during today's event. There will be a moderated question and answer session during today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. A brief online evaluation will pop up on your screen following today's event. Your feedback is very important to us, and we hope that you'll take a moment to complete this survey. I'll now turn the webinar over to Kelsey Breichman, Senior Program Officer at the Center for Healthcare Strategies.
Thank you so much, Travis, and welcome everyone to today's event. I'm really excited you could join us. So for today's webinar, I'm going to briefly kick things off with some introductory remarks and context for our discussion. We'll then move into exploring Ohio's comprehensive primary care program, including their CPC for Kids component. Finally, we'll explore innovations and best practices in pediatric primary care. Next slide, please. And the one after that. Thank you. So my name is Kelsey Breichman, and I'm a Senior Program Officer at the Center for Healthcare Strategies. My work focuses on working with states and other stakeholders to design and implement delivery system and payment reform, particularly as it relates to primary care. I'm really excited to introduce our two guest speakers for today. The first, who will be Mylinda Drake, Alternative Payment Model Administrator at the Ohio Department of Medicaid. Mylinda has been with Ohio Medicaid for 9 years and has had several roles, including data analysis and clinical quality metric development and evaluation. Her current role is Alternative Payment Model Administrator in ODM's Office of Strategic Initiatives, where she oversees Ohio's comprehensive primary care program, the Maternal and Infant Support Program, Integrated Care for Kids program, and other value-based purchasing efforts. I'm also thrilled to introduce Dr. Kimani Coker, Chief of the Division of General Pediatrics and Associate Professor of Pediatrics at the University of Washington School of Medicine and Seattle Children's. As a general pediatrician and community-engaged health services researcher, her research focuses on community partners' pediatric primary care delivery design to promote health equity and eliminate health disparities for children and families in low-resource communities. She is the former and founding research director for Seattle Children's Center for Diversity and Health Equity and serves as the co-director of the University of Washington's NIH-funded Child Health Equity Research Fellowship. Dr. Coker also is a member of the United States Preventative Services Task Force. Next slide, please. So for those of you who may not be familiar, the Center for Healthcare Strategies is a policy design and implementation partner dedicated to strengthening the U.S. healthcare system to support high quality and equitable care, particularly for people served by Medicaid. We work with a wide variety of stakeholders to advance effective models of care, policy and program solutions, and support equitable outcomes for those facing health disparities. Next slide. This webinar is part of the Center for Healthcare Strategies Strengthening Primary Care in Medicaid Managed Care series. Made possible by the Commonwealth Fund, this series explores tools and levers that states can use to advance comprehensive primary care. In particular, we focus on policy, program, and contracting strategies within the context of Medicaid managed care. For additional reading, you can also reference our toolkit that's available on the CHCS website in the link on the screen. This toolkit is broken into modules that include implementation considerations, state examples, and sample contract language on a wide variety of primary care related topics. Next slide. So before I pass the reins to our other speakers, I wanted to take just a few moments to provide some context and focus for today's webinar. So first, what do we mean when we refer to advanced primary care? This slide summarizes the framework that CHCS uses to define core advanced primary care delivery features, as well as the key policy levers that can be used to support advanced primary care. The circle describes what we see as the core features of high-quality primary care, including things like enhanced team-based care, using technology to improve access, integrating behavioral health into primary care, addressing health-related social needs, and engaging communities and advancing health equity. The boxes at the bottom describe policy levers to drive uptake and spread of these capabilities. The check marks denote areas that we've had past webinars and blogs on, so you can find any of that at the CHCS website if of interest. For those areas without the check mark, please be on the lookout for upcoming events on these topics. Today's webinar will particularly focus on setting primary care delivery standards. Next slide. So, when we talk about setting standards for primary care, we're referring to defining and supporting primary care structures and capabilities at the primary care practice level. Just as some context, one common state strategy for advancing primary care practice capabilities is supporting patient-centered medical home implementation. The medical home is a broad framework aimed at providing patient-centered, accessible, coordinated, and comprehensive primary care with a commitment to quality improvement. Many states have requirements for managed care organizations to support PCMH practices, which means that such programs can be an opportune building block for states that are interested in incentivizing more advanced primary care capabilities. Next slide. So on this slide, I've outlined a few of the design questions that states may reflect on during this webinar and consider when developing PCMH or other primary care delivery programs. So first, and certainly a big one, what care delivery capabilities or models should states prioritize? For example, what are the expectations for team-based care or things like integration of behavioral health into primary care? How do expectations for primary care practices align with broader state priorities? It's also important to consider how to implement primary care standards within a managed care environment. So for example, how prescriptive will the states be in setting standards? How can MCOs be held accountable for supporting advanced primary care? And lastly, it's also essential to consider how states and MCOs can support practices in developing new capabilities, whether financially, such as through new payment models, through things like state infrastructure, or things like technical assistance. Hopefully, our webinar today will provide some additional food for thought for folks who are tackling these issues. Next slide. In addition to discussing state levers to advance primary care broadly, today's webinar will have a particular focus on supporting high-quality pediatric care. With nearly 50% of Medicaid beneficiaries being children, states have a huge opportunity to advance children's health. Children have unique health needs that should be considered as part of broad primary care delivery transformation efforts. In designing primary care standards and supports, states may consider how such programs can be leveraged to advance children's health and support lifelong wellness. So with that, thank you everyone once again for joining us today, and I'm going to turn it over to my Linda Drake for her portion of the presentation. Welcome, my Linda.
Thanks, Kelsey. Can you hear me okay, everybody? Kelsey, can you hear me?
Yes, I can hear you.
Great, thanks. So thanks for that introduction. As Kelsey said, I'm here to talk to you today about our CPC for Kids program. Next slide, please. In Ohio, our comprehensive primary care program has the following elements, as you see here. These are more administrative elements. I think Kelsey did a really great job covering what some of our purpose is and what we see as the core kinds of activity requirements and measurements that we would like. But these are elements of the program that we use in the administration side, which include enrolling providers and determining their eligibility to participate, attributing members to those providers to participate in the program, creating activity requirements that include many of the things that Kelsey showed on those earlier slides, including things like behavioral health integration and community services and supports, creating, updating, and maintaining thresholds for our quality and efficiency metrics, including utilization metrics like inpatient and emergency department visits, as well as things like well checks and measures around diabetes, hypertension, moms and babies, and well care specifically are focuses of our program. And we also are responsible for determining what the per member per month payments are for our providers enrolled in our CPC program, as well as what their incentive payments supporting total cost of care reductions and shared savings should be. Next slide, please. So our main goals for our program overall are advancing health equity, driving comprehensive patient-centered care, and promoting affordability and sustainability. Next slide, please. We try to integrate comprehensive primary care in Ohio to many other efforts going on in Ohio to support value-based purchasing and other patient-centered efforts, as well as the future direction we'd like to take Ohio Medicaid regarding focusing on care for individuals. The way that we see comprehensive primary care as fitting within our other efforts and following our future direction is around population health strategies that we have, supporting physical and mental health for all of our patients with Medicaid, integrating that social and cultural framework in our population health strategies. So for many of our populations in Appalachia, in Amish country, our refugee populations, and others who don't necessarily fit our standard framework, we try to work with providers to develop community-specific frameworks that do fit the patient profiles for the communities that they are located in. We also have a focus on maternal health and wellness. We are working on creating a comprehensive maternal care program for OBGYN practices that will mirror our CPC programs in regard to supporting population health activities. And some things we do in our primary care space for supporting maternal health and wellness include looking at longitudinal well and chronic care for moms, trying to link back to that maternal morbidity and mortality that we are trying to affect as Medicaid in our state, as well as ensuring health equity and access to care, which we do in a number of ways in Ohio, and we try to leverage CPC to do that as well. And lastly, we look at whole child success. So in CPC, we are trying to integrate health, education, and family and social supports into our comprehensive primary care program in order to better support the children who are enrolled in Medicaid with us. Next slide, please. So as we went over a little earlier, we do use population health activities, things like integrating behavioral health care, screening for social determinant needs, using team-based care delivery, things in that population health space to better inform how to care for our patients, as well as using those quality and utilization metrics that we talked about, and tying those to our per member per month dollars and our incentive payments. So in order to be in our comprehensive primary care program as a practice, they all have to agree to support those population health activities and attest to doing those throughout their performance year. They agree to be monitored on all of their quality and utilization metrics quarterly and get an annual report. And for that, they will get a per member per month during their performance year and be eligible to receive additional incentive payments depending on their performance on these first two items. Next slide, please. Currently in CPC, we have some ongoing work. We do some continuous improvement work with our practices using quality improvement science, trying to build capacity for new work in this space. We get a lot of questions, for example, about school-based health opportunities, behavioral health integration opportunities, And then as you see next, program interconnectedness, we get a lot of questions about how to work better with our managed care organizations in Ohio, since we are a 90+% managed care state, and trying to figure out how to leverage those relationships, especially in regard to things like care coordination and data sharing, where managed care organizations and primary care practices can really work together to best take care of patients. We also look at our maternal child health and program interconnectedness. As I said, we're trying to draw some even more explicit connections by creating a kind of population health model for our OBGYN practices that could then link directly to our primary care practices to ensure that longitudinal care for women and for their babies throughout their life course while they're on Medicaid. And then lastly, we want to streamline and modernize our CPC program. So some ways we are going about that is to work with CMMI on primary care first implementation. We have begun working on our state plan and working with our actuary to talk about how we might be able to integrate that PCF model into our existing CPC framework in order to update our program to support CMMI's efforts. As well as measure refinement. We're doing some work with CMMI as well on how to be able to collect electronic clinical quality measures specific to the Medicaid space to replace some administrative and claims-based measures we're currently using. Next slide, please. Now I'd like to talk about specifically our CPC for Kids program. Next slide. As part of our current governor, Mike DeWine's children's initiative that he put as part of his platform when he assumed office, we are working with his Children's Initiative Office to coordinate and align our state's children's programming between Medicaid, Department of Health, Mental Health and Addiction Services, Department of Education, Developmental Disabilities, and other programs. We are trying to advance policy and innovation in our children's programming from birth through kindergarten, and we are providing support services for all children and their families throughout our executive branch and our state network. Next slide, please. So what is CPC for Kids and how is it different from our typical CPC program? It's a nested model, so all of our practices in our CPC for Kids product line are also in our CPC program, and it provides additional incentive payments and opportunities in exchange for agreeing to be monitored for some specific children's quality metrics and performing some pediatric focused population health activities. Next slide, please. This is just a program overview of what our core CPC requirements are and what we added on to those in order for a practice to enroll in our CPC for Kids program. So in addition to meeting all of the requirements on that first line that are specific to CPC, so agreeing that they are meeting all 10 activity requirements, looking at those efficiency metrics around inpatient utilization, drug usage, emergency department visits, they have to pass those. And then our quality requirements, which include chronic care measures, well care measures, and children's and moms and babies measures. They have to meet all those, and then they can additionally meet those CPC for Kids metrics and pass those in order to receive the enhanced per member per month payments and be eligible for an additional incentive bonus pool. Next slide, please. So these are our quality metrics that are specific to our CPC for Kids program. The first 4 that you see on the top, all of our CPC practices who see kids need to meet. So well child visits, as well as our BMI assessment. And the bottom are the ones that are specific to CPC for Kids. So all of our CPC for Kids practices agree to conduct lead screenings at least once before the age of 2 and agree to meet our thresholds for children's immunizations and adolescents immunizations. We also monitor our tobacco cessation for ages 12 to 17. So that mirrors our National Quality Foundation tobacco cessation metric for adults. We just modified it for children where that's relevant for things that we know are issues now like vaping. And then we also track fluoride varnish for kids, which can be done in a pediatric office in addition to a potential dental office visit. And we don't count those metrics for the purpose of informing whether a provider is in compliance with their program. They're more just for the provider's information about where they might have some room to improve in their practice space. Next slide, please. These are our bonus activity requirements for our CPC for Kids program. So we are checking to see how the practice offers foster care supports for kids. We have a pretty complicated network of foster care child supports in the state of Ohio because it's led by counties and by some, I'll call them pseudo-governmental organizations that aren't necessarily our county job and family services, but serve a similar function for our kids. We look at behavioral health linkages at their practice specific to the pediatric space. We look at what kind of school-based programming they might offer, whether it's preventive or co-located clinics on a school campus or things in that space. We look at how they conduct transitions of care. So for practices that don't see the whole family or don't follow children longitudinally, how they transition children to adult care, as well as performance on those pediatric specific metrics around immunization and lead screening. Next slide, please. I also want to talk about health equity in our CPC and CPC for Kids programs. Next slide. We originally started with some pretty high-level health equity requirements for our CPC and CPC for Kids program. We did require a patient and family advisory council that was composed of people from the patient community. We required some patient surveys, but we weren't too prescriptive about what those looked like or how often. And we also required some cultural competency training, but again, we're not very specific on what kind or how often. Now, as part of both programs, we include new aspects like we require cultural competency training for everyone at the practice who is patient-facing. We require that practices do take in patient feedback, either through those PFACs or patient surveys or both, and tell us how they're incorporating that feedback into practice policies. And then lastly, we do require some coordination with community entities to better serve patients locally. We allow a lot of practice flexibility since that will look different depending on where in the state the practice is located. But we do ask for some evidence that they have ties to their community network and supports as appropriate for their patient profile. Next slide, please. So we know we still have a lot of space and room to grow in health equity. And some things we continue to do to try to learn more and do more in this space is we continue to have ongoing work on our racial and health disparities. We know that we continue to have Black maternal and infant mortality that's 3 times the rate of white babies in Ohio, as well as white moms. We know that we have life expectancies that are greater than 20 years different between the longest lived and the shortest lived zip codes in Ohio. We know that access to care continues to be an issue in the state, depending on where people live. And we know from our focus group work that people with Medicaid coverage report discrimination or feeling not heard by health providers, especially people of color, people with disabilities. So we continue to ask those questions, and even when they put us in an uncomfortable space, we want to hear that feedback so we know where we still have work to do. Next slide, please. The state of Ohio does have a health equity office. It's new to this DeWine administration. We have a chief of health opportunity at our Department of Health. There's ongoing funding by both our Department of Health and our Department of Medicaid, which in Ohio are separate, as well as our Commission on Minority Health to communities of color with large health disparities. So we all offer grants to community groups in those specific areas where we see the widest gaps and disparities in outcomes. We work with academic partners to identify barriers to access. We've created an index to show us what parts of the state have the most access issues to try to address those. We continue to conduct survey and focus group work to decide where we have additional room to change and grow. We have several examples of surveys listed there. And we are working on a collaborative approach to embedding health equity and update our modernization efforts in managed care. We're calling it the next generation of managed care, and we begin new contracts with new managed care plans on July 1st that incorporate a lot more health equity principles than our previous contracts. Next slide, please. So these are the requirements for our CPC practices in regard to what we require them to do in cultural competency space. So you can see here, we ask that they are able to identify elements of culture and privilege, contributing to cultural skill development, imparting cultural knowledge, strengthening cultural awareness, and supporting the ability of organizations to adapt to diversity and cultural context of the communities they serve. So practices have to attest to doing this and find trainings that fit their community and their practice that have all of these elements. Next slide, please. And this is what we see as the future of health equity and CPC for kids in Ohio. We want to continue learning and growing, continue to get more patient feedback and expanding opportunities for patient input, and providing support to community providers and connections to primary care to better serve Medicaid patients. Next slide. And this is just a slide to talk a little bit more about our next generation of managed care and some of the ways that we want to do better for the people we serve on Medicaid by focusing on the individual. Next slide. I think that might be it for me. So I think there's questions and answers at the end, and I appreciate everybody's time.
Thank you so much, Melinda. Yes, we'll circle back to Q&A at the end. And with that, I'm excited to welcome Dr. Tumani Coker. Welcome.
All right, thank you, Kelsey. All right, so I'm going to get started talking a little bit about innovations and best practices in primary care. Again, my name is Tumani Coker, and I use she, her pronouns. In terms of disclosure, I don't have any relevant financial relationships or conflicts of interest to disclose, but I am a member of the United States Preventive Services Task Force, and what I'll be talking about today is does not represent the views or recommendations of the task force, and overall this presentation should be attributed to me and not to the task force. So I thought I'd start with a quick little story to kind of set the stage. The family I'm going to talk about is not pictured here, but I thought this was a great picture of some families that we have worked with in the past to kind of guide this story for you. So I'm a general pediatrician and a health services researcher, and in my work, I partner with community clinics and practices that serve Medicaid families to do community engaged intervention, design, development, implementation, and testing on really how can we provide effective family-centered comprehensive care to families in low-income communities. So in one of these practices or clinics in Tacoma, a mom and her 2-week-old came in for their first visit with the clinic. There are several social needs identified in the mother. And so the follow-up was another 2 weeks for a 1 month, and then a well child care visit was scheduled for the 2 month. Now, unfortunately, in that time, those 2 visits were missed, and the clinic lost contact with the mom as the phone number was not in order anymore. And so the clinic thought that they lost contact with that mother and her infant. But at about 4 months of age, the mom kind of just showed up at the clinic sort of out of the blue, went to the front desk and asked to see Rosa. Now, Rosa is their bicultural, bilingual parent coach. So essentially a community health worker trained in well child care services, embedded in the primary care team at this clinic through a grant, and had met the mom at that first visit and made that connection with her. So Rosa came out, saw the mom, found out that her phone had been cut off, and she had been homeless with the baby over the last several weeks, going from couch to couch at friend's house. So she connected her with emergency housing and other social services that were in need and got her back connected to the clinic. And so I think that's just a great story in that families often make a connection with various members of a team, which is why we really have team-based approaches to care. So when we think about what is high quality pediatric primary care, I wanted to just bring up this consensus report that was published last year in 2021 from the National Academies of Sciences, Engineering, and Medicine. And I was part of the committee that created this report. And as part of that report, we defined what is high quality primary care. And it's defined in this report as the provision of whole person, integrated, accessible, and equitable healthcare by interprofessional teams that are accountable for addressing the majority of an individual's health and wellness across settings through sustained relationships with patients, families, and communities. And so as you can see here, our real structure of primary care, particularly for pediatrics, is not created with these interprofessional teams, right? They're going to be accountable not only for comprehensive care for the child and family, but also creating these sustained relationships with community. But that's really part of how we can consider high quality primary care. Now I want to talk a little bit more about the idea of team-based care. So in that report from the National Academies Committee, one of the main recommendations was that payers should pay for these interprofessional integrated team-based care to be able to occur. This picture here I have on the left shows just an example broadly of who might be part of that interprofessional team that we need for high quality primary care. It's dependent on the community, it's dependent on the patient needs, and then the family needs, of course, and the resources of that clinic or practice. So you can see here, if this is for a pediatric care, we might have the early childhood specialist, the behavioral health specialist, the school-based support, all as important members of the core team, and then the extended team through the community. So team-based care, it integrates non-clinicians into the primary care team as a regular part of care. We know that it can enhance care for social determinants of health or those health-related social needs that families have. It is an essential part of being able to provide integrated care. The greatest evidence we have is really for behavioral health integration in primary care, but it's also essential for integrating social needs, and there's evidence there, into primary care. Oral health, population health integration, all really require us to have a team in primary care. And then lastly, it promotes health equity, because if we assume that each patient and family is going to come with the same needs, then we're not quite at all really meeting their needs, right? Families will need different elements of care, and the services that a family, for example, living at the intersection of racism and poverty, is going to be quite different than one that does not. Excuse me. So I want to drill down a little bit and talk more about team-based care and a specific element of it. And I'm just going to talk about community health workers and how they can be integrated as that non-clinician as a part of the primary care team. And so community health workers, I'm using this term quite broadly, but can be trained as navigators, as care coordinators, health coaches, and so forth. And the examples in the literature, the examples in clinics and practices, and the evidence that we have is really strong for early childhood team-based care in terms of including a non-clinician in that birth to 3 services. Behavioral health integration is quite strong in that as well. Community health workers have been used in chronic disease management with good evidence, and particularly in pediatric care for asthma. And then really also being able to address the social and medical complexity needs that families have in pediatrics. So some of the things to point out about team-based care, and including community health workers as non-clinicians on the team, is that often they can be community members. They are community members who are trusted by the families. So These are individuals who have lived experience with their families, share a lived experience with their families, and can help build that trust. They help families link to establish community resources and services. It's not enough just to make a referral to a community referral source. We have to actually follow the family, make sure they made the connection, find out what the barriers are, and help them in a warm handoff kind of plan. They can lead the communication and coordination with broader teams from schools to other community organizations, which is really important. And then lastly, can be a resource to provide standardized screening and then the resulting referral services that are needed for that screening in preventive care in particular. So I'm going to switch a little bit and talk more specifically about one particular area, and I'm going to go to that birth to 3 area for team-based care as an example of what this really looks like on the ground. So the American Academy of Pediatrics recommends in its national guidelines of Bright Futures that children receive 10 preventive care visits between the ages of 0 and 3. And data shows that those visits are about 20 minutes with a pediatrician, family medicine doc, or a nurse practitioner. So a pediatric primary care provider. And we know from time motion studies that the time that they have in that visit with their provider is even less than that. So these are the elements of what would be included in nationally recommended guideline visit from Bright Futures in terms of well child care. So the typical physical exam and laboratory that we would imagine. Developmental and behavioral screening, surveillance, and guidance. So at every visit, there's recommended the surveillance to see if the child is on track in terms of development and behavior. And then at specific guideline recommended visits, a more standardized screen to identify those who are at risk for developmental delay and get them into services. And then also just teaching families a little bit about what to expect in terms of what comes next for development and how to enhance the child's development. That leads us to anticipatory guidance, which is the education and guidance that we give families on a range of different issues, from food introduction to car seat safety, sleep safety, toilet training. There's a different, and these are age specific and really family specific guidance and education that families need at each visit. And then finally, the psychosocial and social needs screening and guidance. And so that's being able to identify things like homelessness, intimate partner violence, parental depression, postpartum depression. And then when those things are identified, to be able to not only identify a resource, for referral resource for the family, but then connect with them afterwards to make sure that that referral service has resulted in a useful service for the family, and following up on that. So I like to use this framework as a way to guide kind of how I think about how do we go from structure to outcome? How do we get to the health outcomes that we want? This is Donna Beating's quality framework, which was illustrated a bit more by Barbara Starfield in Dynamics of Health Outcome. And so essentially what you can see here is that we have a structure, which is the personnel, the facilities, the organization, information systems, leading to the process of care. The process of care is really what we do for that patient at the visit, and then the outcomes that we care about, which are the health outcomes and the patient level, the population health outcomes, and then the experiences of care. So with a colleague of mine, Dr. Leonquist, and I last year adapted that framework to really, what does it look like specifically for children in their birth to 3 who are living at the intersection of racism and poverty, and how can we expand that to ensure that they get the outcomes that they need in terms of health and wellness. And so if we go backwards from outcome to get to then the process, these process things are quite well defined, right? The provision of care is defined in our Bright Futures guidelines, which I just went through a little bit with you. And then the receipt of care those are things that Kelsey talked about in terms of the patient-centered medical home. We want care to be accessible, continuous, comprehensive, culturally effective, and so forth. And what we're missing then is going back one more step is the structure, right? We've talked about team-based care, which we know is not at all universal in primary care at this time. Connections with community-based organizations and so forth. So what we're left with is a process that doesn't have a structure to support it. And so when we think about structures that really work, these team-based approaches to care that emphasize relationships have good evidence. And these are just 3 examples that I want to share with you before my last couple minutes are up. So these are all team-based approaches to care for that 0 to 3 age group that puts a non-clinician into the team. In Dulce, it's a family specialist who becomes part of the primary care team from the newborn visit. In Healthy Steps, that's a national program that incorporates a specialist and uses actually a tiered model of care where families receive visits from that specialist based on their level of need. And then this last one is what I've been working on in the community engaged kind of design process where we incorporate a coach into every well child care visit for families to do social needs screening, developmental and behavioral services, anticipatory guidance, all those things that I talked about in the visit. And the evidence here is quite strong in that these randomized controlled trials have shown that this kind of intervention in team-based care for 0 to 3 results in increased services that parents receive, more positive parenting behaviors at home, more up-to-date well child care visits, immunizations, and then finally, reduced emergency department care visits. So this is just a quick picture of one of the coaches in one of these clinics and meeting with the family before the PCP, primary care provider, comes in to really get all these things worked out in terms of providing the education and guidance and the screening and the social needs screening and referral and giving that warm handoff. And some of these findings that I've talked about, I won't spend too much time on. So I think that's about the end of my time. I just wanted to leave you with this slide that really, I think, highlights some of the key elements of team-based care, which includes a connection to the community in terms of community organizations. It's based on relationships with the family. It's integrated in the primary care team in the clinic and really supports the health and well-being of children and their families. I look forward to your questions during the Q&A session.
Great. Well, thank you so much, Dr. Coker. And yeah, thank you everyone for submitting questions to the chat. I see you have a bunch, so we'll move on to answering those momentarily. Yeah, and just again, as a reminder for those of you who might not have asked a question yet, you're gonna click that Q&A button at the bottom of the screen to submit a question, and I'm currently monitoring those. So thanks for submitting. So with that in mind, kind of scrolling through the list of questions here. The first one I have is for my Linda. We had a bunch of questions related to kind of asking more questions about the CPC and CPC Kids model. The first one I wanted to ask is there was a question about, how was it phrased? Someone was asking for a little more detail about what is meant when you say practices must meet performance measures. I think they're looking for kind of, yeah, exactly kind of how you guys set those standards and what you're looking for.
Sure. So there's kind of 2 elements there, the activity requirements and the actual metrics. The activity requirements, we spell out pretty explicitly what we mean when we say things like behavioral health integration. Kind of like Dr. Coker got to alluding to in her talk as well, we want to retain flexibility for practices and how they meet these. We know not every practice is going to be able to have a psychiatrist and a psychologist and a social worker on staff. So we offer a lot of options in regard to things like contracting with other practices that do have those professionals or maintaining some other kind of relationship where we know that if they have patient referrals, those patients will get seen for those behavioral health needs timely and not struggle with access. The other side of it is the actual measurements, so the quality and efficiency metrics. we require that for practices that have at least 30 patients in the denominator for a measure, that they meet thresholds that we set, often using either a percentile in NCQA's quality compass or a kind of internally relevant percentile. So for example, the 75th percentile internally for a metric, if it's something where a national comparison or a comparison to plan performance wouldn't be relevant. And they have to meet at least half of the metrics that they have at least 30 patients in order to be considered compliant.
Great, thank you so much. So kind of jumping over to Dr. Coker, a question for you. So I think oftentimes in terms of health policy, when folks are developing care delivery or payment models, kind of adults are thought of as kind of the default. I'm wondering if there are any particular, or how to rephrase, I'm wondering if there are unique health needs of children that you think should be considered when states are developing these sorts of care delivery models to make sure children's health needs are met.
Yes, absolutely. I think really thinking about the developmental trajectory of kids, right? So if you think about the team that is needed to provide primary care for an infant from, say 0 to 3, that's very different than what's going to be needed to provide care for a teenager. So recognizing that teams have to be flexible and in a sense interchangeable. It's not to say that you can't have, for example, a community health worker who works with the 0 to 3 population, but also works with teens, but recognizing that those are really going to be two different skill sets and levels of training. So I think that's the big piece. And we'll answer one of the questions in the chat on this. And so Bright Futures, that's the national guidelines. That's really is a collaboration between AAP and maternal and child health. And what it does is it sets forth what are our standards of what we need to be able to provide in a preventive care visit throughout the age spectrum. And then the examples of in particular, Healthy Steps and the other examples of those non-clinician team-based care interventions utilize Bright Futures to figure out what services that we need. And I bring that up because in Bright Futures, at the guidelines and the guidance and the screening, it changes as a child goes through their developmental stages. And the other piece is that children they come in a dyad at least, right? So their parent or caregiver and the health of that. And I know, Melinda, you talked about this in terms of that dyad of care and that 2-generational kind of model. So that's another, I think, big difference than we have from thinking about adult primary care. And then just the links with the education, with community, I think have to be super strong for kids to reach their full developmental potential. It can't just be in the primary care setting.
Great, thank you so much for that. A lot to chew on. So jumping back over to Melinda, we had a question, I guess kind of inspired by Dr. Coker's presentation. We had some folks in the chat inquiring a little more about whether you could elaborate on how team-based care is supported or incentivized through the CPC program, whether related to CHWs or perhaps other workers such as to support behavioral health integration. Would love to hear you speak to that.
Sure. So the PMPMs we give practices are not a subcapitated arrangement. They're above and beyond what they get for service provision. So the way that we allow them to use that funding is to support any of the activity requirements. And we've seen practices do a number of innovative things in this space with that funding. Sometimes it's things like upgrading their electronic health record systems so that they have more time to spend with patient care and not doing data entry kinds of tasks. But another thing that some of the practices do is hire somebody like a community health worker or a kind of tool to help with interpretation, or pay for focus group facilitation, or things in that space that can help them do more at a community level to really make that connection that they would not necessarily be able to do, because those are not all providers that Medicaid pays for a service for. Some of them are, but they aren't all necessarily things that can generate revenue in a way that would be sustainable for the practice, but are really, really important to caring for the whole patient. So we're hopeful that the funds and the way that we've structured what the activity requirements are flexible in a way that allows practices to grow their practice in a patient-centered way.
Thank you. So a question that just came in the chat, I think would potentially be interested in having either or both of you answer. Someone's asking how telemedicine or telehealth can be used to help improve comprehensive care coordination, or whole person care. So curious if either or both of you have thoughts on that, what you've been seeing.
I can chime in first. I think absolutely it can be, in particular around care coordination. We had one few years ago, did a project with a federally qualified health center in California, and they're connecting behavioral health specialty services. And they found that they had a really hard time when they made that referral to behavioral health, getting the families into the services. Once they got into services, they were great. We ended up using telehealth as a way to allow the family to make that initial connection with that, with the mental health clinic without having to actually go there their first time. So that's just one example. I think absolutely there are ways that we can use technology, telemedicine, and telehealth to bridge that gap. I do think that we have to be very careful, particularly when they're kind of consumer-driven models, in terms of the populations that are most vulnerable and face the brunt of our disparities are those that also may be impacted by the digital divide, digital literacy, health literacy, just time to be able to access these kind of telemedicine and telehealth functions. So we want to make sure that those technologies narrow the disparity and not widen the disparity. And I think there's definitely an opportunity, if we allow it, that technology, I'll say more broadly, can widen the disparities that we have. But if we use it smartly, as the question highlights, like in rural settings, and make sure that people have the technology and the tools that they need. And I still think, that person to help them connect with it, then I think it can narrow the disparities and get us closer to health equity.
And I can build on that and say that in Ohio, we had an initiative for one of our biggest school districts by geography. So it's a long, wide school district along the Ohio River, where it is very rural. It's part of Appalachia. And it used leveraging broadband in schools and installing broadband in the schools to stretch their behavioral health capabilities for children and families that were part of those schools. So we were able to offer broadband behavioral health-based services in the school setting using those technologies in order to ensure that their counselor wasn't driving back and forth as long as an hour each way to see students at different buildings in the same district, but instead that time could be spent giving more services to students.
Thanks, guys. So I have another question for you, Linda. Looking through the chat, there was a lot of interest in kind of understanding, I guess, how you all selected the quality measures. So curious if you could describe just kind of what that process looked like, what those considerations were. And someone was particularly asking if there was any consideration for developmental screening.
Sure. So for the children's measures, we met with some of our existing CPC practices that were pediatric providers. We already had the well child measures that we included based on some of our population health streams that we use in the state of Ohio to conduct all of our population health strategy work. And we met with a lot of pediatric practices. We tried to get a good representation, rural, urban, federally qualified health center, hospital-based, private practice, and talked about the things that as Medicaid we thought had the most impact from a population health standpoint. So some things that we floated out that did not take, for example, annual dental visits. We really wanted to incorporate annual dental visits as a metric, and pediatric practices just felt really uncomfortable in that space because they felt like there was an access issue. So instead, that's why we ended up with fluoride varnish as an informational metric. The three that we ultimately selected, the lead screening and the 2 immunization metrics, were ones that we felt were directly impact driven by the practices that were seeing the kids. So those were all things that the practice themselves could ensure gets conducted and done, as opposed to some of the more peripheral things we also think are really important to children's health, but maybe are a little bit harder to get at for a pediatric practice. So those are kind of the bonus round space for metrics. So it was mainly working with providers on things we thought were important and hearing from them what some of the opportunities and barriers might be, and picking a set of metrics they thought were a stretch but achievable.
Thank you. So looking at the clock, I see we're nearing the end of our time. So I wanted to ask each of you a closeout question. So Dr. Coker, as your final question I have for you. As a researcher and a pediatrician, I'm curious, what opportunities do you see for policymakers to better support adoption of evidence-based pediatric care?
Yeah, I think for a long time, we have been focused on essentially like HEDIS measures, right? So how many well child care visits does the child have? And are their immunizations up to date? And so it just gives kind of a high level version, but what we really, I think, want to be able to dig down into is like, what are the families getting the services? And that's harder, right, to report, right? It's easier to show that you've had the number of well child care visits by a certain age or the number of immunizations that are required by a certain age. But what we really want to get at is what's in the visit. And I think for so long, we've just said having the visit is enough. But I think we know that like one PCP, one primary care provider, cannot meet all of the needs of any one particular family, particularly if that family is living in poverty and dealing with the stressors of things like racism in their lives and raising a child at the same time. And so, that kind of brings us back to having this team-based care where you're able to integrate someone with lived experience and into the practice. But yeah, really, I think it's about digging more deeply into what's provided in the visit, the social needs, the development, and the education and guidance that families need. And then the care coordination, we didn't get to talk about children with special healthcare needs, but really that level of care coordination too.
Makes a lot of sense. Thank you. And then Linda, as kind of my final question to you, I'm curious if there are any other lessons learned or advice you would give to other states looking to develop primary care models like the ones you all have in Ohio.
That's always a hard one. Yeah, I think just thinking through what the outcomes are that you want and envisioning what could work best and coming up with a good spot of tension between what providers think they can do and what we think needs to be done. So kind of to Dr. Coker's point, we don't really do a good job ensuring that if a screening is conducted, that all of those referrals are followed up on. I mean, we have as an activity requirement, follow up for referrals, but what does that mean? And, a lot of stuff we'd hear from practices, especially in community-based supports, was, hey, we screen positive for this need, but we don't know who in the community could actually meet the need for the patient. So it's coming up with how, from the beginning, to integrate those community organizations and community supports that we know exist in different communities and look different depending on the type of community and the location, but are there, and making sure that practices do make those connections in a meaningful way, not just handing off a patient, but working with the community organization to figure out what works best for them. And I think that that's the next level of doing this kind of population health management work, is getting into the community support space.
Great. Well, thank you so much, both of you, for joining us today. Really appreciate your presentations, given me, certainly me, I'm sure everyone on the call, a lot to think about. And thank you to the audience, everyone who was able to make today's webinar. As I said, today's webinar will be posted on the CHCS website along with the slides. And please do keep a lookout for upcoming events on primary care that we'll be having. So thank you so much, everybody. Have a great day.